And so we did tie-dye day. We actually had patients tie-dyeing t-shirts as part of their recreational therapy. So here's my version of 6100. It began Friday, January 19th, 2018, when I interviewed with Dr. Raj Patel, who's our department chair now. And again, here as an attending, I was hired to develop a brain injury rehab program. And honestly, I don't think they realized exactly what that entailed. Before I had started working here, there was actually they created a certificate of need, and they looked at the number of rehab beds in this area, and the patient population size in general. And they, based on a lot of calculations, they found that 54 rehab beds with 100% occupancy, or 60 beds at 90% occupancy, acute inpatient rehab beds, are required to meet the community need. And at that time, we only had 45 acute inpatient rehab beds with strong and unity. So hence the 11 beds in 6100 to fill that need. And so there's been a need to expand acute inpatient rehab bed capacity and service line programs. And we really have developed service lines. And so we have a brain injury, spinal cord injury, medically complex service lines. Our spinal cord injury subspecialist is starting August 1st. I work with 2 great attendings for medically complex services. But then we've kind of tried to engage orthopedics for recruiting for pediatric rehab subspecialists and cancer rehab subspecialists. But based on the statistics showing the need for more acute inpatient rehab beds in this area, we were awarded a certificate of need from the state. And then COVID-19 happened, and it postponed almost everything, as most of you are probably familiar with. Yet the needs of our community remained, as did our commitment to our patients. So finally, 6100 opened January 2nd, 2024. And while our admission criteria has not changed, the physical space has. So 6100, as a new hire, having just finished fellowship, I was suddenly invited to design meetings for 6100, and they asked me where certain things should go in the rooms, which is fun, exciting, and fascinating, and overwhelming. And so 6100, it has very large rooms. If you compare 512 versus 612, they're much larger. They're private rooms. There's private bathrooms, and then there's family meeting spaces. There's an open area with glass, surrounded by glass for patients, so it's a kind of community room. And so we have water guard capabilities, which would come in handy with one of our patients that was readmitted last night. And there's full visibility throughout the unit. If you haven't been up there yet, please wander up. Feel free to check it out. So who are acute inpatient rehabilitation patients? Who's appropriate for acute inpatient rehab? Okay, these are patients who have functional impairments as a result of devastating injuries, severe neurologic deficits, and complex medical conditions. And they require acute inpatient rehabilitation prior to discharge and return to their community. So appropriate patients have medical complexity that requires daily physician oversight. They have functional needs of at least 2 of 3 therapy domains: PT, physical therapy, OT, occupational therapy, and speech therapy. They can tolerate at least 3 hours of therapy 6 days a week, which can be broken into pieces. We do 30 minutes here and there.
I have to ask a question about that line there. What does that mean? Like, we always get stuck on that. What does tolerate 3 hours of therapy mean? You said you broke into like a half hour. Is that the shortest increment you can have in there that the insurance will approve? Like, how do you guys work that through?
So 3 hours over the course of 8-hour work. Okay, and so we can do 30-minute pieces and give them breaks in between. We can do an hour in between, but they need to be awake and engaged and participating. And as much as that time is a lot.
For 3 hours. Okay.
And then, so they get 3 hours a day, 5 days a week. And then on the weekends, they get 3 hours over 2 days. So it's 3 hours a day, 6 days a week.
Okay.
But they may get 2 hours on Saturday and 1 hour on Sunday, something like that. So we can accommodate patients who need radiation therapy. We can schedule therapy, or we're doing dialysis. We have, right, that part of their workday is required for medical procedure, but we can do therapy and be around it, as long as they can tolerate back to back.
Yeah.
A couple hours. So PT, OT, and speech, as long as they have speech needs, they're not physically exercising for 3 hours. But if they don't, they are physically exercising for 3 hours a day. And while it's not a lot, for somebody like us who walked here, it can be really taxing and make them very tired. So that's where their tolerance comes into play. All right. And then because our bed space has increased dramatically, we are no longer requiring patients to have a home discharge plan. But we do prioritize those who have a reasonable, can be discharged directly home. After an average length of stay of 2 weeks, the average length of stay is for all diagnoses included, okay, medically complex through neurologic brain injury, all service lines included. So patients must be conscious to qualify. I promised my staff, although we have an exception right now, I have promised my staff earlier that they would at least need to be minimally conscious to qualify, okay? Most of our patients in general, we have the spinal cord injury service line, and medically complex patients are in 5 to 100, and 6 to 100 is mostly for the brain injury patients. So my favorite question is, what is consciousness? It's early in the morning, early for you guys here, I recognize that. How would you answer that? What is conscious?
Self-awareness.
Self-awareness, okay?
Perceive and return sensory stimuli.
Okay. So consciousness is, so consciousness is 2 things, okay? You have to be awake and you have to be aware. So self-aware, but also aware of your environment, okay? I give a lot of analogies. I talk a lot with patients and with staff about, raising children. If you ever had seen nieces or nephews or babies or had your own kids, you watch babies when they first are born. How do you know they're conscious? Because they open their eyes and then what, they look around or they cry. But they're able to be awake and aware of what's going on around them. So if you don't have either, you're in a coma, unarousable unresponsiveness. So there's no eye opening, there's no sleep wake cycles. But then eye opening or sleep wake cycles, and I've used this in H12 before, if you cannot open your eyes because of other medical reasons, if you have an EEG that shows sleep wake cycles, you are not in a coma. You are in an unresponsive wakefulness state. It used to be called vegetative state. And so there's no sustained producible voluntary behavior responses to visual, auditory, tactile, or noxious stimuli, okay? So there is no awareness, but there is arousal. Their eyes are opening or they're having sleep wake cycles on EEG, okay? And then usually return to spontaneous or lucid movement is always non-purposeful or reflexive, okay? They don't track. And just to note, there used to be something called permanent or persistent vegetative state. This is now considered chronic. Why? Because of tremendous research that's come out of the Boston area, where we know that some of these patients, even 5-10 years later, will suddenly become conscious. So it's considered chronic. So once they have subtle signs of awareness, then they transition to minimally conscious. Okay, and so they're tracking or command following, very basic communication, verbalization, movements that are contingent to stimuli, not reflexic. This is a challenge often, right, as I'm sure most of you are aware, when families are there and the patient squeezes their hands, well, they do this, every time I put my hand there, they squeeze. Well, okay, that's a grass reflex. And so I'm sure most of you are familiar with that, but this is, they're purposeful responses, emotional responses too. We had a patient a couple years ago who we were she was tracking basic things but she wouldn't track too consistently. So often we're all inwardly focused. So what will you track first is a mirror or your own reflection. So we showed a mirror and she actually purposefully turned away because her appearance was so horrid to her. So it wasn't tracking, it was the opposite of tracking, but that was awareness. So to emerge from a minimally conscious state, okay, you have to have communication that's consistent and more persistent than just basic yes or no, or saying your first name. And you have to use purposeful use of at least 2 objects. So if you look in the therapy notes, the therapy physical or occupational therapy assessments, they do something called the Coma Recovery Scale, CRS-R, Coma Recovery Scale Revised Edition. They do this on a lot of our ICU patients pretty regularly, once or twice a week. And that's a way to quantify consciousness. And actually, if I'm following the patients and I track those numbers over time to see whether or not the patient is improving, it's actually something I would suggest that you pay attention to, because often they have a functional decline in our CRS and then they end up with UTI or then they end up with pneumonia. And so if there is a dramatic change in that, often there's a clinical reason. And so, but if once they have consistent use of at least 2 objects, then they're considered emerged from a minimally conscious state. So disorders of consciousness are due to failure of the arousal system, which, as most of you are aware, is in the reticular formation. Neurons within the medulla and pons project upwards cortically, and regulation of breathing and heart rate. So potential problems in the standard hospital setting are shooting purposeful intent for responses that are reflexic, okay? Inadequate evaluation to detect conscious behavior, insufficient arousal. One of the things that our therapists are really very attentive to usually is that if you're doing a coma recovery scale and you're doing a formal consciousness assessment, the patient needs to be awake. And they need to hear you, and aphasia can often limit that exam too. So they need to be able to wake, they need to hear you, they need to be able to see, their eyes need to work, and then they need to be able to, understand what you're saying. And so in the standard hospital setting, I hope you are aware of these statistics. In the standard hospital setting, we are often wrong. Okay, 41% of the time, the statistic came out of Mass General, which is an academic medical center. 41% of the time, clinicians are wrong, whether the patient is conscious or not conscious. And this is huge, okay? It's almost a coin toss, almost a coin toss. And so actually statistics came out, I'm hoping that most of you saw this, that came out this past month. We often withdraw life support too early. They looked at tons of data that is created with the TRACK TBI study and the National Model System study. And the results suggest a substantial portion of patients with TBI, traumatic brain injury, and withdrawal of life support may have survived and actually achieved partial independence in 10 years. So there are statistics that show that we do, as a medical community, withdraw life support too early. What is not a disorder consciousness? Locked-in syndrome. If you haven't seen the movie Diving Bell the Butterfly, I suggest you do. Post-traumatic confusion state, or post-traumatic amnesia, and brain death. So there actually are recommendations that came out and practice guidelines. And clinicians should use standardized neurobehavioral measures that have been shown to be validated and reliable. So the CRSR, Coma Recovery Scale Revised Edition, that our therapists use a lot in the ICU settings. And this is a form. It's actually, what does this entail? And it tells the therapist spending about half an hour. Take them about half an hour, 40 minutes to actually just look for any subtle signs of consciousness. Because as you know, once somebody is conscious, their prognosis exponentially improves. And we often miss it because we're only in there for a few minutes. And it's tempting to increase arousal, again, being asleep versus being awake. So what do? We give somebody a severe brain injury, with them in the ICU, we say we have to wake up every hour, which I know for medical reasons absolutely do. And then we expect them to give them sedating medications for pain and things like that, which we know that they need. But then we try to decide whether or not they're conscious. Are they asleep or are they unconscious? So there has been a lot of statistics that show that at least 3 formal assessments seems to be the number, the magic number for consistency's sake, for accuracy. And so if they have at least 3 CRSR or coma recovery scales documented, then your likelihood of accuracy is much improved. Okay, and as I'm sure you've seen this study, and from 2021, they looked again through the model systems, lots of data. They looked at 17,000 patients with TBI. 57% had initial loss of consciousness persisted. 2,000 patients were discharged to inpatient rehab unconscious. And of those who were discharged to inpatient rehab, most of them, 82% recovered consciousness during inpatient rehab, and 40% became fully independent 10 years later. So the person in the 318 right now, when I met with the family this past week, I said, there is a possibility that in 10 years, he will be functionally independent, but it may take him 10 years to get there. Again, 50, half of the patients who discharge unconscious to inpatient rehab become functionally or partially independent. So what is it? Why? Why do some of these people do this? What happens? What's the reason? How do we know? How do we know who's going to and who's not going to? That's a wonderful question. I talk a lot about functional reserve. This is one of my favorite rehab topics, okay? The idea of how much of your functional ability can you lose, but still participate in society or still take care of yourself in your daily basis. So the analogy I give medical students often is, if you take somebody who is barely making ends meet at a very a retail job and they're barely holding on and they're barely functioning in society, you give them a severe brain injury, they're not going to go to medical school. But if you give a medical student, you give them a severe brain injury, they probably, hopefully, will eventually be able to live making ends meet at a lower minimum wage job. So prognostic factors, there's tons and tons of scales, tons and tons of calculators, attempts to quantify or to predict very early on who's going to recover and who's not going to recover. Because there is 50%, 40% who recover, but a good portion of them don't. So how do you know if the person in front of you, which category they fit in? Positives. Honestly, the most reliable things that I have found are these. I don't use any of those scales. I don't, clinically I don't. Positives are eyes open within the first 72 hours. Okay. Ages under 55. I say to people all the time, as I get closer to that number, it sounds a little more scary. I say, when I hit 55, I'll probably start saying 65. But in 55, in the neuron world, when you hit 55, you're considered old. Okay. Medical comorbidities, bilateral brainstem injuries. Bilateral brainstem injuries. MRIs are important, are helpful, because if they have bilateral brainstem injury, the likelihood of their positive outcome is actually much lower. Okay. Severe disability is unlikely if post-traumatic amnesia is less than 2 months. And good recovery is unlikely if post-traumatic amnesia is over 3 months. The problem with post-traumatic amnesia is that it can't be determined until patients are fully oriented. And usually at that point, families stop asking, are they going to get better? But that is the most reliable and consistent predictor that we have, the duration of how long they are confused, how long are they disoriented. So this is 2 patients that I have seen over the past few years, and I want to show you an example of something, okay? Patient A is an 8-year-old man with a history of diabetes, one remote cardiac concussion. He fell off a roof, caused a grade 3 DAI, okay? So he had a brainstem injury. Baseline GCS was 4, PTA was 28 days, okay? Top screen causes for marijuana, okay. He had a lot of fractures, Patient B, 9-year-old man, okay, otherwise healthy, and a grade 2 DAI. Not 3, 2, okay. PTA was about 20 days long, actually baseline GCS was 3. He was intoxicated. And as I'm sure most of you know, alcohol is actually protective in car accidents. This is not a recommendation to go out, get drunk, and then go to car to avoid a severe TBI. But we know that unfortunately, alcohol is associated with recovery. Okay, he had polytrauma. Lots of fractures also. So those are the big things. But both of them had tremendous family support. So A, he fell through the roof. Okay. So this is his image. As you can see, there is a brainstem lesion. And then B, he had just a grade 2 DI. Okay, but he had a lot of frontal injuries. So a lot of frontal injuries. That's his image. Okay. So patient A, last saw was maybe 3 years after his discharge from Strong. He was living at a happiness house, which is a supported environment for patients with a severe TBI, with severe cognitive deficits and neurologic deficits. He was walking, but it was walking ambulatory, able to do his own, basic ADLs, but nothing more. He was embarrassed to report visual and auditory hallucinations. He had showers talking to him. So moderate disability. Okay, patient B, a lot of things 3 years after his discharge from Strong. He was living independently. He was working as a project manager at I think Deloitte, a very big firm. After finishing his degree in construction management, he graduated with honors. So he had a good recovery. So the question I have for you is this one lesion in the brainstem the reason between a good outcome and a bad outcome? Is that the reason between psychosis and high functioning? We don't know.
But it's a marker of the amount of force that the brain sustained, and it's correlated with the outcome, but not the cause.
Right, correlated but not the cause. It is, that is a good point. But we don't know if that in and of itself is there's a lot about the brain we don't know. There's a lot we don't know. And then, so maybe it is a marker though, right? So patient C, she's 58, so she's a little bit older. Car accident caused grade 3 DAI, so this is bad, okay? PTA was 35 days. So it's a little longer than those 2 younger guys, okay? GCS is 3, she had a lot of fractures. She had C1, C2, and axial rotatory displacement, which you, I'm sure, know much more about than I do. It's kind of below the brain, but this is her image. She had a very, very large brainstem injury, okay? Very, very severe injury, so yes. Then she was discharged from rehab. She had a ground level fall. She came back to the ED, then came back to rehab again. But I saw her a year later. She was independent for ADLs, ambulatory without a device, being left alone intermittently in her house and participating in her IADLs. She was starting to learn to drive and to function. No psychiatric concerns. Her recovery was not finished. It's still not finished. So we don't know. There's a lot about the brain we don't know. But she also had tremendous family support. So there's a lot we don't know about prognosis, despite multiple attempts to create all sorts of formulas. Even the most robust predictive values are limited. A lot of my mentors, and I agree, have said that, you know, genetics likely poses a significant component. We don't know we don't know. And I'm sure you've heard, they started trying to map the brain. And they did a very small area and it took a lot of computer space, and they're trying to do a rodent now. It's gonna take a lot more computer space. And then they calculated that if they tried to do the human brain, it would take the entire current internet, availability. And so that we don't have the technology at this point to map the entire brain. But in summary, a traumatic brain injury is the recovery after a TBI is dependent on the quality of the brain that sustained the injury. How do you know what quality of the brain sustained the injury? What were they like beforehand? I'm the person in the ICU saying, what was their job? How far did they go in school? What was their function? What was their life like beforehand? It's very challenging to determine the quality of a pre-injury brain, as I'm sure you're all aware, but we can do the best we can. So that's great, but what happens here? What happens at Strong, AUR? Okay. So as some statistics, here is Strong Memorial Hospital. And these are the statistics that trauma has provided as far as the number of severe head injuries, moderate severe head injuries that we've seen over the past few years. Okay. And there are a lot of variables that we may consider when we consider somebody who's appropriate for acute injury rehab, but this is not all exclusive. We used to say they had to be over 6 years old. That has changed. We are now we're working towards accommodating kids who are much younger. We have a child right now who is smaller, who's on weight-based dosing. And so we're thinking closer to 2 years is where we're headed. Medical stability and medical complexity, which is a fine line. Functional needs, endurance, potential to discharge home safely, again, past potential, accessibility of home. We actually had a lot of donations recently from former patients that are willing to help us with requiring ramps. So ramp is no longer a need for a ramp at home is no longer a barrier. And the support, again, we consider that. Other patients on the rehab unit. Unfortunately, every time we think about who is there, we have to think about what kind of space is there, the Strong census, and then what kind of beds are available, and who else is out there. Insurance and all variables included to that, and then challenging medications. Sometimes we can't, there's certain chemotherapy medications we cannot give. But nothing is black, white, nor is it absolutely, it's all gray, as I'm sure you're familiar with. So I do recommend you reach out to us. I hope you do. I hope that you've had great communications with some of myself and some of my colleagues. If not, please let me know. There's tons of ways. I'm sure you're inundated all day long. If you wanted to do Lord of the Rings smoke signals, I probably would respond to them at some point. All right. So our staff, when 61200 opened, there's lots of concerns, as I'm sure your staff have too. Okay, most staff here, challenges to fill vacant positions, epidemic of violence in the hospitals, insurance authorization barriers, strictly enforced restraint policies, and patients with minimal or no reliable home support. That's been challenges throughout the hospital, okay? And then there's just too many patients, as I'm sure you're all familiar with. But we work really hard. Insurance companies are very, we negotiate. We do a lot of peer-to-peers. Okay, so thank you all for what you do. Really, thank you all for what you do, for sending us patients to effective teams of positive outcomes. I'm sure you're all familiar with Desiree Rosedale. If you are not, she's a nurse here right now. She had a severe TBI. She's back in the OR. Kyle Farr was one of the patients who I talked about. He works for Denver. Okay, and then Wendy Stone is another patient who was working for the FDA, and she's back there now after a car accident. So we're still hiring. Yeah, go ahead.
Not to admire you down on this topic, but it's the inevitable topic is point number 2 there is insurance company barrier and staff negotiate. That's something that, could you just take a 30 seconds and lay it out for us what that means? Like, what does that mean? Like when there's the staff negotiating, because we are, we're a lot of times you guys are also there, but we're also interacting with the patients directly and their families. And they're kind of like being like, what does this look like? What is your average time? Can you just give us a lay of that, what that means for your
Sure. So patients are, I appreciate the question. So patients are, we see a patient clinically. I see somebody for consults. I say they're great. They've got they meet all my check boxes clinically. And then I look at my administrator and they're put on a list. We have a list of our transfer center list. So there's a list of patients who are good candidates. And then we go through that list and they are clinically approved. And then they are administratively approved. There are 2 separate things. And so clinical improvement, if you see what we call a pre-admission screen in the chart, that means we have submitted to their insurance. So once that shows up in their chart, it's in a different encounter because we create a pre-admission encounter, but is it a different, if you see that note there, we have submitted to their insurance. Usually we try and tell them to you guys too, but we know that we submit to insurance. And then it's about, well, we submit that document, and then we submit their most recent therapy notes, their most recent therapy evaluations documents, and we also submit their most recent progress note. And then the insurance company reviews it, and there's been all sorts of things all over the news recently, who reviews it and how thoroughly that's done. There are certain parts in those notes that they look at. We have learned through some denials and some peer-to-peer discussions what those variables are, what those unwritten requirements are. So we've worked with our therapists, our consult therapists.
Yeah, so we want to know the secret too, so.
What's the secret? Okay, so the secret is, honestly, I'll be totally blunt. The secret is Excelis says that anybody after a stroke should not be walking further than 50 feet in order to qualify for acute inpatient rehab.
Okay.
Which is crazy. So the numbers, but honestly, the number, like 50 feet is how long, right? So the number that they look at is they look at how much assistance they're walking, how far they're walking. So I've also told my therapist that they're not allowed to walk people over 100 feet. So if you see PT walking people for 300 feet, documenting that, doing stairs, they're trying to clear them from home.
Yeah.
They're not thinking rehab. Okay. And then OT, they look at toileting. And everything else, yeah, but toileting.
So what's their key with things?
So that's the thing, those are there, and honestly, what do they focus on? They focus on the box next to the specific thing. So it says ambulation, and there's a box next to it for how much assistance, that's what they read.
Yeah.
There's a toileting and how much assistance, that's what they read.
Yeah.
Okay, and then I will tell you, I did have a, every once in a while, I talk to somebody who has a decent medical background. And they'll say, I did have someone say, well, they look like they're still not, they're not medically stable because of, I don't remember what it was. And I was like, well, because of something that the progress note had said. So it's justification of needing consult services to be involved. In all honesty, Tyler, at some point, I probably will drop you guys a message that says, hey, can you agree to follow this person while they're in rehab? Because that will help me justify medical complexity.
Yeah.
If I need another acute service, to see them, you know, if I promise for it, I'll promise that, you know, hospital medicine needs to co-manage their blood pressure or whatever. Like, that's great. That'll justify it. What else? And then things that cannot be done at a skilled nursing facility. Agitation is a big one. The person who came back to our unit last night because he was very agitated. As soon as I was like, we got this. Insurance is gonna prove it no matter what. He's walking, he has minimal OT needs, but he's agitated. And that was an easy one. So for TBI, that's pretty easy. Bladder management, for spinal cord injury, bladder and bowel management, if it is not figured out yet, we can usually argue with that if we haven't figured out all those details. Blood pressure, risks for anaphylactic reflexes and things like that. Medications that a skilled nursing facility cannot give. So chemotherapy agents, you know, oral even, things that are too expensive for them. Radiation therapy.
Is there anything that so like I have this policy that I always write in the chart. Like I say, I'm the progress note for that day, every day. I say, this patient is a great candidate for inpatient rehab. Am I just talking into the sky, or is there actually looking at that? Do they care at all what I say?
Yeah.
You can be honest. I want you to be honest.
In all honesty, I am not sure. I don't know. I don't think that would be that's a bad thing. And I also will tell you that you can always write that. And then if we say they're better for a skilled nursing facility, a SNF will still take them.
Yeah.
Okay.
Okay.
You can, so I tell the therapist too, like, you can always write acute inpatient rehab, and then a skilled nursing facility will probably approve them, you know, unless there's some severe medical thing that the nursing facility can. But otherwise, you can always send people to a lower level of care.
Yeah.
So we actually work with our therapists over the past couple of years to not write acute versus skilled. They just write inpatient rehab. I'm sure you've seen that. And then we just say, and then we make the decision, we make the call. So that to minimize that barrier. We have that problem in our satellite hospitals. One therapist will write acute and they'll send us a consult, and the other therapist is writing skilled nursing facility. And I'm like, as soon as the therapist writes SNF, they're not even gonna think about it. They're not gonna bat an eye.
It's amazing. I'm sorry. I mean, it's it's such a frustrating thing, I imagine, for you guys, just as it is to us. Like, you know, your job gets boiled down to like an insurance company argument, like what little words they're looking for on a piece of paper. But it's valuable to know that, you know, there's no negative of writing this patient is an acute rehab candidate, because I think it helps the patients feel like we're helping them. You know, they're like, oh, like, you know, the doctor wants me to do this, and even if the insurance, the evil person is the insurance company, not PM&R. Because like there's always like this like animosity that some patients feel of like they won't take me to rehab, and it's like it's not them, it's your outcome and also your insurance company, and so I want to I try to offload that from our services to, you know, the great evil of the insurance company, for lack of a better word. And, you know, and obviously there's like a lot of factors in that, but I try to avoid that conversation by putting it on, you know, another group of people.
Oh, I appreciate that. I really do.
Is that what you want us to do?
Yeah, absolutely, absolutely. So, I mean, I have gone to patients' room before and I said like, look, I'm fighting for your insurance company. I need to know X, Y, and Z. You know, just so you know, I got a text message a couple years ago from an Excelis person that pretty much wrote like, there's no money for acute inpatient rehab anymore. And so I sent it to this, my department chair, who sent it to the CP in the hospital, and that went very high up. It was in writing, like, oh, yeah, right?
Yeah,
I would love to take every medically disabled person here,
Yeah.
I would, they're a great rehabilitation, that's why we actually, I'm more than happy to follow people if they get denied. A lot of us are too, like, not just me, but a lot of us are trying to, we want to do the best thing for our patients. There are a few people in our outpatient clinic who are more than happy to see people who are sent to a skilled nursing facility, especially they're interested in spasticity management and, other management. And so if you have somebody and you're like, oh, they're not going to be approved for rehab, but I could use a rehab consult, I could use somebody to double check what they're doing in a sniff, definitely reach out to us, let us know. We're happy to set them up. Okay.
yeah. And when it comes to like the time frame of when, they're going to be considered a candidate, would you consider somebody that has not had a neurostimulant started? Such as that, like, how does that?
That is an outpatient decision. I've been told.
Okay.
I've been told a neurostimulant is an outpatient decision.
Okay. I was always curious, because that's something we always comes up, like a lot of trauma doctors ask us about that. It's like, oh, like, they're not very conscious, but maybe if we started modafinil, they'll be wake up enough that they can get inpatient rehab. But I'm like, I mean, that's a, like it's.
Consult me. I'm more than happy to help. Because honestly, often those people are also on sedating things during the day.
Yeah.
And their neurochecks are Q an hour, My 7-year-old son had his tonsils removed last year. I had to give him Tylenol every 4 hours, and that was hard. You can imagine having a severe brain injury and then being in the in ICU with the lines and things you don't understand, and then being woken up every hour. Like that's, okay. Anybody else? So, since it's a grand rounds, I figured I should give you some more education. After traumatic brain injury, it is expected that people are agitated. That's an expected part of their recovery. As I told my secretary today, the person who we have right now who's very agitated, he came to us minimally conscious. So he was a Rancho 3, minimally conscious, localized response. I said, great. When he wakes up, he's going to be agitated. We have another person who did not have a traumatic brain injury. She had encephalitis and severe encephalitis. And so she is not going to follow this scale. When she wakes up further, she is not going to be agitated. She's minimally conscious right now. She's not going to be agitated. She probably will not, not guaranteed, but she probably will not. It's expected. So as people are confused and agitated, as they become more oriented, they become less agitated. And so if you've ever raised a child, I talk about how comatose is, or vegetative state, unresponsive wakefulness is your kind of infancy stage. And then you do go through the terrible twos and terrible threes. And this is where you don't know what's going on, but you're pulling at things and you're screaming and you're crying and you're determined to do what you want right then and there because you don't have the executive function that works. Okay, so what do? We stop stimulants. Okay, fine. However, what a stimulant is supposed to do is help you go faster through these stages. So the agitation is expected, but it may help you go faster through this. Tyler, I want you to know too, when you talk to the trauma surgeons, that the thing people often don't recognize is in the amantadine paper from 2012, the Neurology paper that everybody quotes that made it so popular. Their post hoc analysis, they actually looked at people who it was started later on, and those people did better.
Yeah.
And so I always say you don't need to rush to start a stimulant. You got to get them off the sedating stuff during the day before you start it, because they actually may do better if you wait. Yeah,
pretty much. Yeah, that's always nonsensical to me. It's like they're on a propofol drip off like long, but we're also blasting him with a mantis. What are we doing here? Like, there's like this balance of like.
So yeah, I like the PPID and
it's like the introduction to Wolf of Wall Street. Like get me down. And like, it's like
you don't need to do amantadine and quetiapine at the same time. Like they're just working together.
Yeah.
So this is my when I saw was first born, my husband is Chinese, hence the last name, and my father-in-law coined the picture. And this is bath time every week. And so if you have kids, you know what this is like. But this is the Rancho 4. Okay. The problem is that they are larger than infants. We can't just pick them up and force them to do things. Okay. So when we have now is bigger than me, and I can't force him to do anything. He's gonna hit me. Which is why he was in 4 restraints in the ED yesterday. But overnight, he was not in any restraints last night because our staff behaviorally managed it. So changes in emotion after TBI, right? Attention and concentration problems, impulsivity. As soon as sound happens, you turn your head and you have to go in that direction. Memory problems, okay? I can tell you in 2 minutes later, you don't remember what I just said. And executive function, impulse control. Okay, so when agitation occurs, what's the first thing you do? What's the first thing you do?
Talk to the patient.
Determine the cause. And usually it's not by talking to the patient.
Hey, sir, how are you?
Hi, all right, how do I move this? Okay. It's okay, okay. Patients who are still on post-traumatic amnesia will not remember anything, true or false. If they're still confused, will they remember anything? True or false?
False.
False, good, okay. Because emotions, as you know, go through a different location in your brain. Emotions are stored. So this patient who came back to us last night, still in severe PTA, but he recognized himself and we were nice to him. And so we were nice to him before. And so he associated good emotions with us. But DPS, when they show up there, they want to put him in restraints. And so it makes it worse because he associates the emotion. He doesn't know why, and he doesn't remember what you do, but he remembers how you feel, right? It will never remember your name, it'll always remember how you made them feel. So we talk a lot about behavior plans, a lot of behavior technicians who do this. Behavioral interventions are hard, but they lead to much better outcomes. This is my favorite critique. People watch too much TV commercials about drugs they don't really need. And so I think they have a pill for that too. So we had a great interdisciplinary meeting this past week about this patient we got right now. And I just said, no, I'll start him on Depakote. We'll just start him on medication. Got our acid to help his agitation. And my therapist said, no, don't do that yet. We think we can handle it. So agitation, if you characterize agitation, is it emotional? Is it angry or is it confused? Okay. Are they reactive, impulsive? Are they aggressive or do they have problems with arousal and they're just fearful? Lots of causes of agitation: constipation, urinary retention, sleep-wake cycle disruption. I think a lot of your patients probably have that, okay? Lines and tubes that are irritating. I don't know what that is, but I want to pull it out. Feeling hot or feeling cold. On my expectations, the person was supposed to help me. They were supposed to take the line out of me. They were supposed to do something that made me feel better. Carriage transitions. Patients get agitated around 5 o'clock. How come? Because that's when nursing shift change happens. That's when everybody goes home. Too many visitors and too much stimulation, right? So we actually, as a interdisciplinary group, made this patient come from the ED to our inpatient rehab unit last night because in the ED, there was too much going on and he was just angry. So sleep. I hope you've seen this study, especially residents. What's the difference between a physician who's intoxicated and who has not slept in 24 hours? And the answer is not much, which led to duty hour restrictions that came out a couple years ago. So common causes of agitation, okay, sleep-wake cycle disruption, I label that a lot. Constipation, urinary retention, especially in men with a prostate who have a stroke. Older man with a prostate who had a new CNS injury, okay, bladder, urinary retention, or having incontinence down. What are common side effects of immobility, neurologic injury, and or opioid medications? Urinary retention, constipation. What are we gonna do? We're gonna give them an injury and then not let them sleep for the night. There's medical reasons for that. Please recognize that. I know that there are good medical reasons for that. But I want you to see that we're just setting people up for a situation that makes things sometimes worse. So on 512 and 612, we actually quantify agitation. This is not something that's used anywhere else in the hospital, but I'm happy and my staff are happy to educate people who are interested. The agitated behavior self. Why do we do this? We have a flow sheet and I actually am able to track what time they get angry and when it happens. And if they get agitated around 4 o'clock or 5 o'clock when shift change happens, I'm going to send trazodone around 3 so that it tones their level down and then they don't get angry. And they can go to a nursing facility like that, or on a scheduled valproic acid, and do the same thing around that time so that they are not as agitated when things happen. So yeah, lower scores are when therapists are in therapies during the day and they're engaged in structured tasks. And then 3 to 5 o'clock, they're like, I work for the day. I'm supposed to go home. I'm supposed to get my paycheck and I'm done for today. Okay, so we talk a lot with our staff about self-preparation, knowing where you are in space, and being calm and gentle like a kindergarten teacher. Be nice, but respecting people's personal space, okay? And it's a big focus is on safety, as I'm sure it is for you guys too. So the thing that I tell people all the time is emergence from disorder consciousness is not like the movies. They're not going to go from laying in a bed to running around screaming. They may hold a pen correctly, and they may take a washcloth and try to bring it to their face. Or they may take a cup and try to drink from it and not just squeeze it or drop it or throw it or lick it or whatever they're supposed to do. And so that's emergent. And then resolution post-traumatic amnesia, they're not gonna go from being confused to working a full-time job the next day. Okay, so if people in the ICU ask me, how long before my loved one can go back to work? Even early on, I will say, I always tell people a year. If you're gonna ask me this early on, I'm gonna give you the number that I tell everybody, and there are some people that do it a lot faster. As Rosebell was determined to do it less than a year, and she did it in about 7 months. But I just say about a year. All right, I don't want to go too much over. So medications for agitation. If treating the underlying cause environmentally doesn't work, then you do have to use medications. Trazodone, quetiapine, mirtazapine, hydroxyzine, olanzapine. I write in a lot of notes, and I've done that before. Don't use haloperidol. How come? Because it interferes with their motor recovery later on. There's just statistics that show if you give somebody with a severe TBI Haldol for agitation overnight, it's going to cause motor recovery problems later on. And nobody in the world is ever going to publish a case report, but I do know that it has happened before where a resident is on overnight and somebody's agitated and they just give them Haldol because it's, they're in the ICU, they're agitated, that's what you do. And if you give somebody with a severe TBI Haldol, you can put them into NIS, neurologic malignant syndrome, and people have died. This has happened. So to prevent agitation from happening, and diazepam, we all know that benzodiazepines cause mild kind of impairment in healthy people. So don't give a benzodiazepine to somebody who's not healthy, whose brain isn't healthy. To prevent agitation from occurring, propranolol, divalproex, or valproic acid. Divalproex is better on your GI system. And lamotrigine. Lamotrigine is less sedating. Sometimes we use it more for kids. Propranolol can cause some orthostatic hypotension, but if they can handle that, that's a great one because you've got a lot of space to go, a lot of room to go there. So will a neurostimulant help? It depends on the reason for the agitation. If they're agitated because they cannot focus, then the stimulant's gonna help. If they're agitated because they're angry or they're aggressive or something, it's not gonna help. Sometimes stimulant medications exacerbate the situation. So there's lots of stimulants, lots of things that we use. Lots of times I think about starting a stimulant, arousal, awareness, attention, memory, impulsivity. But I'm always addressing sleep first. And I know that there are lots of good clinical reasons for you to do what you do. But I also see it as my role to just point out to you that as soon as you can stop waking up every so often, as soon as you're allowed to do that, please do. As soon as you can make the environment better, please do. As soon as you can leave opioids and benzos, please do. I know that right now, they probably need that. They probably have a seizure risk, and so right now, they need to be getting the Haldol and the diazepam and Valium. But as soon as you can do that, please stop it. And so the Samantinian study that you're all aware of from 2012, and the thing I tell people all the time is they went to 11 different places to get 184 patients. If you think about any of your stroke studies, your anticoagulation studies, they've got thousands of people. So will Amantadine ever be FDA approved for brain injury recovery? No. Why? Because the study, the patients are not, there's not enough patients to enroll in a massive clinical trial like that. And there are lots of neurotransmitters involved in wakefulness. We've got stimulants for all of them. So the question is, what stimulant should we start? The answer is probably, I'm happy to weigh in. I'm more than happy to weigh in, okay? Because there's lots of reasons for this. There's lots of reasons I think about when to use, what to use, and why. We got things for norepinephrine. I used to say there was no stimulant for histamine because you wouldn't give somebody a systemic histamine reaction. And then they come up with one that is just centrally acting. So there's actually a centrally acting histamine medication now, stimulant. Dopamine, serotonin. Serotonin has been it's stimulating, but the studies have been kind of inconclusive. Abigail and acetylcholine. So there is a very interesting study. I'll leave you with this. A very interesting study. Flora Hammond has a great chronic TBI population. And so these are all patients. She had 190 patients who had TBI at least 6 months earlier in the study. And she showed that amantadine did not positively impact cognition in this patient population. And actually, they did, when she compared them, she looked at placebo versus amantadine. And you can see that the placebo patients did better, and the amantadine patients actually did worse over time. So we still don't know. The jury's still out. But again, this was only 119 patients. And as you know, there's so much diverse anatomy, right? So much diversity in where your injuries are, where your DAI, where are the lesions? Where exactly did they happen? What is your problem? Okay. I'll stop here. Yeah, well,